may hit some collaterals, so patient may bleed and patient may land to emergency. So adequate needle gauge should be selected before doing biopsy, and it's CCT is a must for doing biopsy from the liver, because it will give you an idea of the vessels and vascularity and the lesion vascularity also. So CCT is a must before doing liver biopsy. And the tumors such as SCC, they also show very variably FDG uptake. But when there is FDG uptake, you can attempt for biopsy. But when no FDG uptake, better not to do PET-CT guided biopsy. And what else is needed? So we have to check the serial scans. If the lesion is decreasing in size, no need of doing biopsy. Even my interventional friends are sitting there. They will also prefer not to do biopsy when the lesion is decreasing in size. So what are the steps to doing biopsy from the liver? First, we have to select the target lesion. We have to target the transitional area. FDG PET-CT help to avoid the necrotic area of the lesion. So the next step is patient positioning. How we should position the patient on the bed while doing biopsy. Patient should be lie down in the ipsilateral side down position. That will reduce the respiratory motion of that side, and there will less respiratory motion over that side, and you can approach the lesion very well. So next is entry site. We have to look at the entry site. When patient is having cirrhosis, we have to look for the collaterals at the side of the entry, palpate the intercostal space, whether rib is palpable or not, and anesthesia can be given at the skin surface along with the liver capsule because they are painful. So the next step is trajectory. We have to plan the trajectory. While approaching to the lesions, we have to take a small cuff of the normal liver tissue to avoid the bleeding. So normal liver tissue is there that will act as a tamponade, and there will be less chance of bleeding. So always have a normal tissue in the trajectory that will avoid unnecessary complications and avoid direct penetration of the capsular lesions. And always avoid pleura, and when you are approaching in the posterior approach, because that will lead to unnecessary complications. Advance in small increments. Never go in one way. And so you have to go slowly to the lesions, and at each step the respiration should be suspended. So I'm showing few cases. 86-year-old female with the constant symptom of symptoms. 3-phase CT and arterial enhancing lesion was there with the CLD, and query STC was there, and PIVCA was also normal, AP was also normal. US guided biopsy was done. Probably they may have hit some necrotic area. So this patient was referred for PET-CT and guided biopsy to us, and we did PET-CT guided biopsy from this lesion. We went slowly to the lesions, and we targeted the FDG avid site, and it turned out to be metastatic neuroendocrine carcinoma. So this is a second case, 64-year-old male with ascending carcinoma prostate. On staging PET-CT, on PSMA PET-CT, we see that there is a lesion in the prostate, and another non-PSMA avid lesion is seen in the liver. So the urologist suggested us for do a FDG PET-CT and biopsy. So we did FDG PET-CT, and FDG PET-CT, this lesion showing FDG uptake. We targeted this lesion, and that turned out to be follicular lymphoma. The next case, this is a 63-year-old female having carcinoma of breast, post-surgery and chemotherapy and radiotherapy. On follow-up, there were multiple SOLs were there, and we targeted FDG avid site that turned out to be metastatic carcinoma. So after the biopsy, we have to do a check scan to look for hematoma, and patient should be kept for under observation for 4 hours. And vitals should be checked every 15 minutes for at least 2 hours, and it's suggested to avoid the strenuous exercise for one day. And what would be the complication to be noted in liver biopsy? Patient may have bleed, that is the most common complication. Intraprocedural bleed may happen, so we can use coil while doing through the coaxials, or we can inject FFP and platelet through the coaxials, and a post-procedural plan for blood transfusion if there is significant hematoma is there or bleed is there. And sometimes if you puncture the bile duct, patient may have biliary peritonitis. Patient, if you are puncturing the pleura, patient may have pneumothorax. And sometimes if you are not following the guidelines and not following the surgical sepsis, patient may have abscess or tumor seedling will be there. But nowadays we are using coaxial needles, so chance of tumor seedling is minimized. So next target is retroperitoneal biopsies. There are many indications for retroperitoneal biopsy. It could be lymphoma, metastasis from other malignancies, inflammatory condition would be there, infection and glomerulus pathology will be there. So large cutting needle can be used for should be used for retroperitoneal biopsy because ISC is always needed for these kind of regions, and cross sectional guidance is utmost important for retroperitoneum. Then ultrasonography and FDG PET provide information on the metabolic character of the lesion. So coming to the contraindication of retroperitoneal biopsy, because in the retroperitoneum there is ureter is there is gonadal vessels is there. So better, these are the they may lead to some complications. So better to avoid these two structures. And in pelvic lesions, we may have bones. So a direct approach would not be there in the pelvic lesions. And obviously uncorrected coagulopathy and patient is non-cooperative. They are also contraindication for doing retroperitoneal biopsies. Now the steps of doing retroperitoneal biopsy. First, we have to select the needle. Then we have to do imaging. It's better to have a CECT that will delineate your vessels, and not to forget renal vessel and gonadal vessels because they are in the paravertebral locations, but you may injure them and patient may land somewhere else. So better to look at the renal and gonadal vessels and ureter also. So the next is entry site. Entry site should be infiltrated with the local anesthesia. Avoid vertebra. If you are by chance touching the vertebra, better to use local anesthesia. And after that, you plan your trajectory, prone, oblique, or lateral. Better to avoid this psoas muscle, like Lara principle. If you puncture the psoas, patient may have bleeding, or piercing the pleura can be done, but always avoid pleura because unnecessarily patient may have pneumothorax. So this some cases of retroperitoneal biopsies. This is a 36-year-old male, incidental detected thrombocytopenia with cervical lymphadenopathy. FNAC was suggestive of query Hodgkin's disease, query ALCL, and PET was done. PET was suggestive of cervical lymph node and retroperitoneal lymph node. And this patient biopsy was done from the retroperitoneal lymph node, and which turned out to be Hodgkin's lymphoma. And this is a second case of 62-year-old male having NHL, high-grade large cell lymphoma, post-chemotherapy. As compared to last case, there was complete resolution of most of the lesions, but one retroperitoneal lymph node was persisting, and we had given a dual score of 5, and we did biopsy from this retroperitoneal lymph node, and that turned out to be residual disease. This is a 56-year-old male with carcinoma right breast. Initial PET revealed isolated lesion in the RUL. Patient underwent lobectomy for that, and follow-up CT and CT chest and abdomen were normal. After 2 years, patient again landed to PET CT to do a PET CT for reassessment, and follow-up PET CT revealed a tiny nodule in the pelvic cavity. And this patient was suggested for ultrasound guided biopsy, and on ultrasonography, the lesion was non-discernible. And he was again referred for PET CT guided biopsy, and we did biopsy from this lesion that turned out to be adenocarcinoma. Now, coming to the post-procedural care in retroperitoneal biopsy, a check scan is always needed in each and every biopsy. Post-procedural patients should be kept for observation, and vitals should be checked every 15 minutes for at least 2 hours. And retroperitoneum is usually safe. If vascular anatomy is delineated, you have to know the vessel anatomy. There is outweigh the risk. The coaxial system must for operable tumors to prevent the seedling of the cells. Tumor seedling is not an issue in inoperable patients. So coming to the contraindication for pancreatic biopsy, pancreas is near the pancreas there are many vessels are there. So patient nearby a large aneurysm and pseudoaneurysm may happen. Nearby varices may be there. That will lead to some bleeding complications. Uncorrected coagulopathy is also contraindications. And if patient is non-cooperative, that is also contraindication because there are a lot of vessels nearby. So we have to take care of all of these contraindications. And endocrine secreting tumor, like as insulinoma, theoretically risk of hormone release will be there. So they should be approached very carefully. And step-by-step procedure for doing pancreatic biopsy. First, we have to select the needle. Coaxial needle prevents seedling. FNA can be used. Double action needle can be used, or single action needle. And imaging for pancreatic biopsy, CCT is always preferred because we have to delineate the vessel anatomy. So CCT is required. We have to identify the MPD because if you puncture the MPD, patient may have pancreatitis or biliary infections. So now decide the entry site, inflate the local site. We have to check the collateral form. Collaterals is there or not. Portal venous occlusion should be checked. And after that, trajectory is planned. Avoid the normal gland. Like in liver, we are puncturing the normal liver, but in the pancreas, we have to avoid the normal gland. Posterior approach is avoided in pancreas because in the posterior aspect, there is vessels in the pancreas. Splenic vessels are there. We may puncture the splenic vessels, so patient may have complication related to splenic vessels puncture. You have to advance slowly and displace the bowel loop with the blunt needle and go to the lesions and take biopsy. So now few cases of pancreatic biopsy. This is 64-year-old male, small cell carcinoma lung with involvement of the mediastinal lymph node and isolated pancreatic lesion. There is a mass in the tail of the pancreas. So along with there is bowel loop is there, spleen is also there. There is bowel loop is there, spleen is there, and how to approach these lesions. So we step by step we went to the splenic lesions. We displaced the bowel loop with the blunt needle. We went to the there is some hematoma is also there at the entry in the peritoneal cavity, and we slowly we approached the pancreatic lesions and we did biopsy from the pancreatic lesion that turned out to be metastatic squamous cell carcinoma. Now in the anterior approach. We can also do anterior approach, but in anterior approach there will be multiple collaterals will be there. So it's better to go slowly in the anterior approach because you may puncture the collaterals. So I'll always use blunt needle while doing anterior biopsy from the pancreas. Is a 61-year-old male with the right kidney RCC with pancreatic mass. Whether it's metastasis from the pancreas or whether it's second primary. So we did biopsy from this pancreatic lesion that turned out to be primary pancreas. So post-procedural care in the pancreatic cancer, pancreatic biopsy, we have to do check CT, patient should be observed, vitals should be checked, and complications, patient have bleeding, pancreatitis, patient have sepsis, cholangitis when you puncture the MPD, and tumor seedling will be there. If you are, but when you are using coaxial, tumor seedling will be minimal or no seedling will be there. Now coming to the renal biopsies, indication historically, it is mainly done for cystic lesions. Present role for lesions with solid component and diffuse parenchymal disease, renal biopsy is done. Angiomyolipoma, the diagnosis is image diagnosis. If fat is there, that is pathognomic for angiomyolipoma, so biopsy is not needed. Not all solid lesions are tumor, so that they can be granulomatous, fungal mass also. Better diagnostic results with cutting needle over FNA is also preferred. FDG PET has a limited role in RCC, but it will give you some target lesions when it is FDG ability is there. So coming to the contraindication for renal biopsy, like uncorrected coagulopathy, non-cooperative patients, special precautions when there is double vessel is there, collecting system is, we have to check the collecting system, ureter should be avoided, large tumor tends to have necrotic centers, so we have to target the periphery for parent lesions, target lower polar avoid damage to the medulla and segmental arteries also should be there. And what are the approach of doing biopsy from renal biopsy? First, we have to position the patient prone, oblique, lateral spine, lateral side down position is preferred. And imaging CCT should be done because we have to delineate the vessels. Renal splenic pedicles can be approach should be done through renal splenic pedicles, and we have to remember the gonadal vessels and IMV. Entry site should be infiltrated and palpate the rib and give local anesthesia over there. Then trajectory should be planned lateral to the erector spinae is a better approach. Avoid colon in that lateral approach. Advance slowly. We slow increments, and breath holding should be used. So coming to a few cases, a 65-year-old male intermittent fever, 2 year with the dysuria. Bilateral DA stent was placed, and patient placed for ureteric stricture. Patient was on ATT for 2 months, and we did a biopsy from the renal lesion, and that turned out to be IgG4 related disease. This is a 31-year-old gym trainer having a known case of Hodgkin's lymphoma. And on FDG PET CT, we can see multiple FDG avid sites are there in the thoracic regions. And on follow-up PET CT, thoracic lesions are also still persisting over there. And additionally, there is appearance of new renal lesion is there in the left kidney. So we did a biopsy from the left kidney that turned out to be tuberculosis. Now, post-procedural care is almost same. Vitals should be checked. Now coming to the complications, patient may have bleeding and hematoma, and needle track seedling will be there. AV fistula formation sometime may happen. Now coming to the adrenal biopsies, the indications of adrenal biopsies: cross-sectional imaging preferred over the ultrasound guided biopsy in adrenals. Indication is presence of the mass, either malignant or infectious. Inhomogeneous enhancement in adenomas or FDG PET CT positivity must be sampled. Small lesion less than 5 cm with lipid-laden adenoma are usually benign and need not required sampling. So contraindications, the contraindications are same, except if patient is having hypertension, better to check for the biochemical profiles, and alpha blocking agents should be kept ready for managing the hypertensive crisis, and patients should be admitted for adrenal biopsy. Now coming to the adrenal biopsy approach, first we have to position the patient and root, either prone, oblique, posterior paraspinal, lateral spine, and parahepatic, and sometimes peripancreatic approach can be approached. But if first we have to do CECT to delineate the vessels, avoid the fluid filled or the cystic areas of the mass. Entry site should be infiltrated with local anesthesia, palpate the rib and give local anesthesia over there. Then most desirable route is oblique route, avoid the vascular structures. Right side between the left, if we are approaching on the right side, between the liver and the kidney should be, the approach should be between the liver and kidney. If we are doing from the left side, behind the, we have to approach behind the tail of the pancreas, medial to the spleen and anterior to the kidney. And second most desirable approach is posterior paraspinal route through the crura of the diaphragm. And sometimes transrenal approach may be approached, but very limited. It's very limited use and very rarely tried. And sometimes transhepatic approach is also tried, but that it have high complications. Bleeding may happen, not in the peritoneum, also in the liver also. So this is a case of bilateral adrenal showing FDG uptake, and along with there is crura and pleura is also there. So we did biopsy from this adrenal lesion, and in between rib is coming, we had given local anesthesia at the rib, and we approached slowly to the through the crura to the adrenals, and that revealed histoplasmocytosis. So this is a 46-year-old female patient treated with non-small cell lung cancer. Follow-up PET CT revealed adrenal nodules, and we did biopsy through the kidney, and that turned out to be metastatic carcinoma. So post-operative care is almost same. Patient, because they have hematoma, patient should be observed, and we have to check the vitals and complications. Patient have bleeding, hematoma, anterior approaches have higher complications. Transhepatic and right adrenal biopsy have also bleeding chance. Transpancreatic biopsy, patient may have pancreatitis, and if we are approaching through the pleura, patient may have pneumothorax also. So now coming to the next biopsy, that is splenic biopsy. There is spleen is a vascular structure. There is high risk of vascularity. And because of vascularity, there is high risk of complications. The tumor of the spleens are rare. The risk of biopsy outweigh the benefit for the procedures. FNA can be done over the cutting needle biopsy, but the recently said biopsy over FNA have almost equivalent complications. So coming to the absolute contraindication for biopsy from the splenic lesions: uncorrected coagulation profile, patient is non-cooperative, close proximity to the vital structures. If hypervascular lesion is there, they are relative contraindication for splenic biopsies. Step-by-step approach. Patient positioning is utmost important in splenic biopsy. Left lateral position or ipsilateral down side down position is the best approach. So imaging is better to have CECT to delineate the vessels. Then entry site should be prepared. Then A post-procedural patient may have hematoma or bleeding, so hemostasis injection should be performed. Gel form, thrombin, and coils should be used while doing splenic biopsy. But if no bleeding is there, there is no need of doing gel form, thrombin, and coil. So this is a 47-year-old female patient with NHL. Post-treatment, no splenic lesion was there. So we did biopsy from this splenic lesion. We approached slowly, and this turned out to be rectal transformation. This is a 26-year-old female abdominal TB. He was on ATT and not responding to splenic. This was not responding. So the diagnosis was in dilemma, TB versus lymphoma. FNA was attempted. This was inconclusive. So we did a PET guided biopsy from this splenic lesion that turned out to be TB. So splenic biopsy check scan is always needed because patient may have hematoma, bleeding. So patient vitals should be checked regularly. Bleeding and hematoma are the most common complications. And because of high vascular organ, pneumothorax may happen if you puncture the pleura. And mesenteric biopsy, CCT, is always used for looking at the mesenteric vessels and splenic aneurysm. And there is a difficult approach in doing mesenteric biopsy because they are movable. And there may be bowel loop also, and the oral contrast can be used to delineate the vessels. And there is increased chance of bleeding if cutting needle is damage the normal mesentery. So how to approach the mesenteric and peritoneal biopsies? This is 5-year-old female with constipation and loss of appetite. Tumor markers were within normal limit, and she had a past history of THB, a total abdominal hysterectomy with BSO. Tumor markers were within the normal limit, and there was a lesion in the peritoneal cavity that was showing FDG uptake. So we did biopsy from this FDG avid site. So that turned out to be foreign body granuloma secondary to a sutural material. And this is a 69-year-old female, chronic abdominal pain and ascites and peritoneal thickening and omental deposits. So we did biopsy from that lesion that turned out to be malignant. And we have published our data in European Journal of Nuclear Medicine, and we had found that PET-CT guided biopsy is very highly a practical approach to doing targeting the abdominal pelvic lesions. And the PET-CT guided biopsy was pathological diagnosis was established in 97% of the patients, and it is utmost important when the conventional biopsy is negative. PET guided biopsy can be attempted. Thank you.
So let's move from soft tissue to skeletal. So where we move to skeletal biopsy, some of the lesions on the imaging, it's suspected to malignant, or there are some unconfirmatory lesions. Some diseases on the based on the PET-CT or CCT images, like a hematological malignancy, where we required the PET-CT guided biopsy. And there are some infective pathology where we require some isolation of the microorganism. There are the common indications. So we will discuss about the percutaneous biopsy in this slide presentation. So pre-procedural workup remain all near same as soft tissue biopsy, but we are including the surgical consultation at the entry site and route of biopsy at the time of deciding of the biopsy. So contraindication is also relatively same, but only the contraindication we have added. Sorry. The soft tissue infections and the impending spinal compression. About the technical factors, all the relatively same as to soft tissue biopsies. There are two common techniques, coaxial and tandem techniques, and we are commonly using the coaxial techniques. And they are it's a pure skeletal lesions, there is no soft tissue component, we are using the trephine biopsy gun. If there is a soft tissue component is there, we are using the cut-in needle. So this is a trephine biopsy needle. It's a GEM-CD needle. So we are commonly using now a diamond tip needle for the spinal biopsy. This is a soft tissue biopsy gun. It's when the skeletal lesion has a soft tissue component when we are using this type of gun. So planning at the time of the planning, the surgical oncologist or orthopedician should be there at the time of the intervention planning. So there are various approaches in the spine. There are commonly we are using the two approaches: the transpedicular and the extrapedicular. This commonly the posterolateral. In the dorsal spine, transpedicular. If extrapedicular, then we are using the costovertebral or costotrans approaches. I am showing the few cases. Like in this case, we have a lesion in the dorsal vertebra, and to target this lesion, we have to use the transpedicular approach, and we have to target this lesion from this left lateral component, and reaching up to the target site is when we have taken out the samples. It's a malignant sample. In this case, we have used the extrapedicular approach from the right lateral side, and when we have taken out the sample from this lesion, it's turned out a metastatic differentiated carcinoma, thyroid carcinoma in the thyroid cancer patient. If there is some soft tissue component, when we are using the soft tissue biopsy gun additional to the in this lesion also, it's turned out a necrotizing granulomatous inflammation. In not only we are approaching to the vertebral lesions, we are also approaching the other side. Like in this side, in this case, we are doing the biopsy from the pelvis, and we are using the ischial tuberosity in this case, and we have taken out the sample from this patient, and it's turned out a diffuse large B-cell lymphoma. So in this case, we have taken out the sample from the sacrum, and we found it's after the biopsy, it's from sacral lesion is a large cell lymphoma. And we are also approaching some long bones. And in long bones, we are showing some demonstration of the biopsy from the femur, left femur, and after the biopsy, it's turned out as a Hodgkin's lymphoma. In this case, we are also showing we are not only going for biopsy from long bones and vertebra, we are also targeting some peripheral sites like scapula and rib. In this case, is adenocarcinoma of prostate. We are targeting the scapula, and we after the biopsy procedure, and it's turned out as a metastatic adenocarcinoma from the prostate. It is demonstrating the case from the rib lesion. We have targeted this rib lesion, and after the biopsy, it's turned out as a LCH. So about the sampling, and when we are doing is some sample collection is different as compared to the other sites in soft tissue biopsies. In the sample collection, when we are reaching up to the target site, we are trying to extract the bone marrow. It's not possible in all the cases. If possible, we are extracting the bone marrow from the sample site, and then after we are starting to taking out the sample. And second thing, what we are doing when we are retracted the bone pieces from the target site, we are preparing the imprints by the using of 2 slides for possible of early results. Complications like hemorrhage, infection, tumor seedling, procedure-related fractures, and unretrieved devices fragments. Commonly, we are facing the tumor seedlings. So for the tumor seedling is a common problem. So we have to ensure the needle path is anticipated region of the surgery. So we have a very good publication from the PGI Chandigarh about the bone biopsy. And
Next, in 5 minutes. Our next slide is this is a video of PGI. So there are many diagnostic tools to have biopsy from the prostate, like DRE, serum. We can do digital rectal technique through transrectal ultrasonography, through the transperineal approach, or through transgluteal approach. It's it's not very defined. So we can use ultrasonography for doing biopsy, transrectal ultrasonography. Even we can use MPMRI to target the lesion. So all they have very negligible chance of picking up the lesions, because doing through the transrectal approach, If you are doing through the digital examination, you will target uh, the nodules only. If you are doing under MPMRI, you are targeting the Pirates lesions that will also have lesser sensitivity as compared to PSMA PET CT. So there are many approaches described. I'm not going to discuss the approach over here because of very less time. So according to ISMO guidelines and EAU guidelines, MPMRI should be done upfront before doing biopsy. In a patient who have suspected for prostate cancer with rising PSA levels, MPMRI should be done upfront, and after that biopsy should be planned. In trust-guided biopsy, it is done from the 12 core biopsy. It is done from the both lobes. 12 core are taken, and if we are doing under MPMRI, we have to do 12 core along with one biopsy from the lesion that is described on MPMRI, and yield of the transrectal biopsy is around 50%. And even we do repeat biopsy that have very less chance of picking the lesions. So after first negative biopsy, saturation biopsy is done if they are poking your prostate 50 times, and the detection rate is around 18 to 34%. And if the number of the core is directly proportional to the number of the complications, so higher number of the complications will be there if multiple cores will be there. So they are poking your rectum 50 times, the chance of complication will be enhanced. So you may have chance of UTI, you may have chance of bleeding, and patient may lead to sepsis. So there are very defined complications like hematuria, rectal bleed, hematuria, bacteremia, all are the defined complications. And septicemia is also noted in 5% of the patients. So gallium PSMA, all know well-defined, that have well-defined role in prostate cancer imaging. So there is nothing to, I will not read this slide. So what is the need of doing a PSMA PET-CT guided biopsy? Target is obvious. At the same time, whole body PET-CT can be done. Additionally, PET-CT help to detect the pathological lesions before the appearance of the anatomical lesions. And PET-guided biopsy should be ideal approach of doing biopsy from this PSMA with prostatic lesions. So we started this clinical trial of doing biopsy from these prostatic lesions under robotic arm. So we selected patient with rising PSA level and with elevated PSA levels with Pirates 3 and equivocal lesions with focal lesions on the PSMA PET-CT. So we also recruited patient who had no access through the rectum, patient with post APR. And metallic implant also, patient having metallic implant in which MPMRI cannot be done. So patient preparation, I'm not going to discuss. Patient preparation is almost same. So in this, what we need is patients. We need urine culture examination. That is at most important because patient may have infection. So urine culture should be there, and patient can be put on antibiotic, and along with the coagulopathy that should be checked, and patient should be position prone. It's not working. So this is a small video. I'm not going to play because of shortage of time. Now deciding the site and approach of the biopsy. The 68-year-old male patient with history of lower urinary tract infection. Patient had hematuria. Urinary cytology was suggestive of urothelial carcinoma. Prior transrectal biopsy was done, and PSA was 8.8. So we did PSMA PET-CT. What was the approach of doing PSMA PET-CT guided biopsies? This is transgluteal, transischial fossa, right or left pararectal approach, then going to the prostate and taking biopsy from the prostatic lesions. This is the transgluteal, transischial fossa, then pararectal, and then going to the prostatic lesions. So we have published our data in radiology, and what we found that PSMA PET-CT guided biopsy is highly diagnostic, and up to 56 patients we picked lesions in the 54 patients, and there were minimal complications reported in the patients. Only 1 or 2 patients had complications. And now coming just last slide, comparison with the US guidance and PSMA guidance. Lesion is always obvious on PSMA PET-CT guidance, and lesion is never obvious on US guidance. And there is more chance of complication in US guidance approach as compared to PSMA PET guidance approach. The yield is around 50% in PSMA PET guidance, in ultrasound guidance, as compared to 96% in PSMA PET guidance approach. Now, coming to take home message, transglottal PSA PET guided biopsy is feasible, safe, and has excellent diagnostic performance. Highly practical approach in patients with prior negative trust guided biopsy and having PET positive lesions. It negates the chance of inoculation of the prostate with the rectal flora, so the morbidity will be minimized. So the finding of our results pave way for PSA PET CT and upfront PSA PET CT guided biopsy for early detection of the prostate cancer. This is our, we have two robotic arm machines with one fluoroscopy. This is our department. I am thankful to Professor B.R. Mittal for giving me all the opportunities, all the machines. And I want to share the experience of this patient. Sorry, time is limited, but not playing. Okay. It's fine.
Thank you, faculties. Thank you, chairpersons. We would like to hear a comment from the chairpersons, both being the interventional radiologist, and then we'll quickly move on to the inauguration.
So just a query, are all of these done Robio guided or are they, because most of the images were freehand?
Sir, we are doing robotic arm guided also. We are also doing under fluoroscopy also. We are also doing freehand also.
Because with the Robio, I think one issue is respiratory motion, which respiratory motion and patient motion, because we have tried them and what happens is that the lesion is very small. You've shown some very small lesions. I don't think they're Robio guided.
A small lesion in the
Because
lower
in
lobe of the
lung-
lower lobes of the lung, they are hard to approach through robotic arm. They have some system of respiratory gating, but that is not too good. But upper lobe lesions, they can be approached under robotic arm, sir.
And do you have something over a respiration motion? Do you have?
Yes, we have system for respiratory motion gating.
Are you using it?
We are hardly using that.
One more query was that you have written in very bold letters, ascites is not a contraindication for liver biopsy. I don't think that is a very correct statement.
Relative
I mean,
contraindication.
huh?
That is a relative contraindication.
So you have written not a contraindication. I mean, that is, I don't think the people who are sitting here and the students, they should not go home with that message that ascites is not a contraindication for liver biopsy.
Sir, I don't know how many of them are doing biopsies.
No, I mean,
But
at least they should not go
this
down.
can be doable, sir.
And that paper was 1988,
Yes,
I think.
yes.
So I think.
But it can be doable, sir.
And also, I would like to know your experience on, you have written injection of platelets and FFP through the coaxial needle. Is that something that we have tried?
Yes, we tried FFP once.
But is FFP available right there?
No, sir. Actually, patient was admitted in the ward.
So you left the needle there?
No.
Then?
Patient had FFP along with that on that day.
Then you again injected the coaxial and put FFP?
Coaxial was there, sir.
Huh?
Coaxial was there. Patient was on blood transfusion, and they came with FFP along with that.
Because in our institute, FFP takes like 2 to 3 hours to come.
No, patient was planned for FFP, sir. Yes.
Anyway, great presentation. Yeah.
Thank you. I'll hand over the stage to Dr. Vindhya for the inauguration now.
Distinguished delegates and my dear colleagues, a very good afternoon to all of you. I, Dr. Vindhya Malasani, attending consultant in Sarvodaya Hospital, am delighted to welcome all of you to Vivanta Surajkund for the inauguration of 21st Annual Conference of Associations of Nuclear Medicine Physicians of India, powered by Sarvodaya Healthcare. It gives me immense pleasure to be standing in front of all the esteemed personalities who have won so much to nuclear medicine as a field which led to the position we are right now in India and globally. The Associations of Nuclear Medicine Physicians of India was formally established in 2003. The principal agenda for its conception was to promote the field of nuclear medicine in the country and to establish cordial relationships with the other branches of nuclear medicine. Since its inception, the association has grown from strength to strength and has aided in conducting annual conferences, regular seminars, CMEs, and academic sessions for the students, and also provided a great platform to the members to exchange their ideas and share their experiences. Today, on behalf of Society of ANMPI, I take the privilege of welcoming all of you to this 21st annual conference. The theme for this academic phase is Nuclear Medicine, Nuclear and Beyond, with an aim to cover topics in nuclear medicine related to gamma imaging and latest advances in PET imaging and a special focus on theranostics. In the entire journey of annual conferences held by ANMPI till now, for the very first time, we have introduced the concept of pre-conference workshops for the students and consultants. Our organizing chairman and sitting president of the society, Dr. Venkatesh Rangarajan, is not there among us because of some unfortunate event in his family. To start the proceeding, may I have the pleasure of inviting Dr. Uma Ravishankar on the stage, past president ANMPI, and she is representing Dr. Venkatesh Rangarajan, the organizing chairman of the conference. It's my privilege to welcome Dr. Path S. Chowdhury, the scientific committee chairman, onto the dais. I'm glad to invite our organizing secretary, Dr. Swagat Dash, onto the dais. With equal pleasure, I invite co-organizing secretary, Dr. P.K. Arora, onto the dais. The next dignitary to honor us with his presence is Dr. R.V. Parmeshwaran, the President-elect ANMPI. May I now invite Dr. Vijay Harish Somasundaram, Secretary ANMPI, onto the dais. I take the privilege of welcoming our guest of honor, our patron and chairman, Sarvodaya Healthcare, Dr. Rakesh Gupta sir, onto the dais. May I now invite Dr. Uma Ravishankar to felicitate our chief guest, Dr. Rakesh Gupta. May I invite all the dignitaries onto the dais for lamp lighting ceremony. कुन्देनु तुषारहार धवला या शुभ्रवस्त्रामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युता या सरस्वती भगवती निशेष जाड्या I now request Dr. Uma Ravishankar to open the scientific sessions and
fellow nuclear medicine enthusiasts. I stand here before you today with immense pride and privilege as we gather to inaugurate the 21st Association of Nuclear Medicine Physicians of India conference. It is an honor to welcome all of you to the vibrant city of Delhi, a hub of culture, knowledge, and innovation. We have assembled here to celebrate the remarkable strides made by our community and to foster an environment of learning, collaboration, and progress. Our journey in nuclear medicine has been a journey of dedication, commitment, and unwavering passion. As we look back, we can see how our field has evolved and continues to evolve thanks to the relentless efforts of nuclear medicine physicians across India. It is your dedication that has led to breakthroughs in diagnostics, treatment, and research that impact the lives of countless individuals. In our quest to eliminate the darkest corners of disease, we have harnessed the power of technology, innovation, and a deep understanding of the human body. We have not only diagnosed diseases with precision, but have also contributed significantly to improving patient care and outcomes. Our tireless efforts have brought hope to those in need, and today we gather to celebrate these accomplishments. Delhi, with its rich history and vibrant culture, provides the perfect backdrop for us to come together and engage in scientific deliberations. This is the city that has been the birth of great knowledge. We invite you all to not only partake in the scientific discourse, but also to soak in the rich cultural heritage of this incredible city. Throughout our time here today and for the couple of more days, let us strive to learn from each other, share our experiences, and take home valuable insights that will further enrich our practice and elevate the standard of care that we provide. Let us forge new collaborations and nurture existing ones, and for it is in the synergy of our collective efforts that we will continue to push the boundaries of what is possible in nuclear medicine. As we embark on this journey of discovery and collaboration, let us remember that our work impacts lives, brings relief to their sufferings, and offers hope to those in despair. It's a privilege and responsibility that we carry with us, and it is that unites us in our shared mission. In closing, I want to express my heartfelt gratitude to each and every one of you for your dedication and unwavering commitment to nuclear medicine. Together, we will continue to illuminate the path towards a healthier and brighter future. Thank you, and let the scientific deliberations begin.
May I now request Dr. Path S. Chowdhury to say a few words.
Dr. Rakesh Gupta, Chairman of Sarvodaya Healthcare, the dignitaries on the dais, colleagues, my dear friends, fellow students. I don't have a speech ready. I'm just going to speak whatever we have done in the scientific program. This year, we have tried to bring forth few new ideas, which in the morning you must have seen, the pre-conference workshops, regarding the writing of reports and other things, because we always need to know that as we delve in our journey forward and become more and more into the clinical medicine, the reports what a clinician decides must also be structured properly. So in this, we have tried to make whether we can actually go for a structured reporting. Similarly, we have introduced few other things in the scientific program, which we'll see over a period of time. This year, the focus has been on the youth specialists of today, because I must admit that the younger generation today who are practicing nuclear medicine are phenomenally enthusiastic, well-read, and really work with a passion. So therefore, we are here to share our knowledge with them. Of course, the seniors are there to mentor them. And side by side, we must have some knowledge from the international community. And I am very happy to say that we have Professor Hossein Jadwar, Professor Stefano Fanti, Professor Shobhan Vinjamuri, and Vineet Pant, and Nagaraj, and Masha Maharaj from South Africa here with us, who will also share their knowledge and their expertise, and we all grow together. So enjoy the conference. We would definitely like a feedback on the scientific program from all of you, and especially the younger generation, and how we can improve in the subsequent years. Thank you.
May I now request our guest of honor, our patron and chairman of Sarvodaya Healthcare, Dr. Rakesh Gupta, to share his thoughts.
Good afternoon. It's my proud privilege to welcome one of you, all the delegates, all the senior faculty, to this 21st annual conference of Nuclear Medicine Physicians of India. I must thank the organizers for giving us the opportunity to be the co-host or to be some part of the conference by hosting it. I welcome you to the city of Faridabad, the part of NCR. It is a hugely evolving healthcare hub. A lot many institutions have come up. As a physician, I look towards nuclear medicine as an utter curiosity, and I am amazed to see the way it is unfolding from simply being diagnostic to now therapeutics as well. Each day a new technique comes up, each day a new therapeutics comes up, each day we are enriched by the contribution of nuclear medicines to the world of physicians. Me as a physician is hugely helped by all the possible diagnostics which are made available to us. And as an entrepreneur, I see as almost a selfish thing that so many new nuclear physicians are now upcoming. The dearth of nuclear physicians which were there few years ago is no more there. Now, lot many courses are being run. Lot many youngsters are being getting trained in nuclear medicine, including the latest developments in all the possible institutions. So, such conferences do help in bringing us together in evolving a new world of nuclear medicine. And I'm impressed with the theme as nuclear, new medicine. So, nuclear has got a new word now, nuclear. The theme is beautifully done, and I'm very sure that all the delegates will be immensely benefited with this conference, both in the workshop manner as well as in the deliberations. And I'm very thankful to all the learned faculty from India as well as abroad who will be contributing their experience, sharing their experiences with their fellow beings, with us people, as well as they'll be training the upcoming physicians in this field of nuclear medicine. I wish this conference a very huge success, and I'm very sure every one of us, including the industry, we people as physicians, all the nuclear medicine physicians will be immensely benefited. All the best. Thank you.
Now I request Organizing Secretary Dr. Swagat Dash to give his concluding remarks.
Hello everyone. A warm good afternoon from ANMPICON Secretariat. I thank you all from bottom of my heart for making this conference such a big, huge success. And I welcome you all to enjoy the conference. We have put in our blood and sweat to make it happen. Enjoy it. There are 2 more days remaining with a lot of scientific events and merrymaking also. So enjoy and do give us your feedback. Thank you so much.
Good evening, everybody. I'd really like to congratulate Dr. Swagat and the entire team for this setup. We know the difficulties you went through to make this happen. Just a quick announcement before we go forward. I just want to announce that the students who have submitted abstracts, which have been accepted, both as the posters as well as oral presentations, will be getting a travel grant from the association. Just that announcement. Thank you.
We will just wait for a couple of minutes for people outside to come in. Good evening again. I welcome you all to the most important part of our conference, Dr. R.B. Lele oration. It's a proud privilege for me to introduce or tell you about a very eminent teacher and father of nuclear medicine, Dr. Ramachandra Dattatreya Lele, sir. And he has been the ex-director of nuclear medicine and RIA at Leelavati Hospital and Research Center, emeritus director of nuclear medicine and ex-medical director of Jaslok Hospital and Research Center, emeritus professor of medicine for life and ex-dean Grant Medical College and Sri JJ Group of Hospitals, Mumbai, and dean academic of All India Institute of Diabetes. Dr. Lele has been the ex-member of the AERB board from 1999 to 2001, ex-member of the editorial board of Journal of Nuclear Medicine USA, Journal of Nuclear Cardiology USA. He has been the former president of SNM India in 1989, former editor of Chief of Indian Journal of Nuclear Medicine 1990 to 1996, first president of Indian Medical Informatics Association, which started in 1993, has been the first president of Nuclear Cardiological Society of India, which also he was the founder president and started in 1994, first president Society of Free Radical Research in 1999, he was the first president Indian Ethics Committee India since 1999 and emeritus professor of National Academy of Medical Sciences. As you can see, he holds the first, he has started many organizations for the betterment of nuclear medicine in our country. He has received innumerable awards, of which a few are listed here. He is the Distinguished Community Service Award of Rotary Club of Bombay in 1990, the first recipient of Gifted Teacher Award instituted by the Association of Physicians of India in 1991, the Padma Bhushan Award 1992, Dhanvantri Award in 1997, Honorable Degree DSc, NTR University Health Sciences, Andhra Pradesh in February 2020. He has multiple publications and he has authored 7 books. We still have some of his old books in nuclear medicine, which we still refer to. So, after this brief introduction, it is my proud privilege to call upon Professor Hussain Jadwar to the stage, please. He will be giving us the R.D. Lele oration. Welcome, sir. Professor Hussain is a professor of radiology, urology, and biomedical engineering from the University of Southern California, Los Angeles. His education, you can see that he is a biomedical engineer, PhD in biomedical engineering, MD medicine from University of Chicago, MPH public health from Harvard University, business administration from University of Southern California. He has done his internal medicine internship from University of California, San Francisco, residency in radiology and nuclear medicine, a fellowship in PET from Harvard, and now he is pursuing his law. And so you can see the broad spectrum, of his educational qualifications. And again, he also has multiple awards. We would like to just highlight some of the awards. Next one. Next, please. Yeah. Next. Selected honors and awards of Professor Hussain. Distinguished Investigator, Academy of Radiology and Biomedical Imaging Research, Distinguished Scientist Award of Western SNMI, Lifetime Achievement Award of ACNM, Peter Walk MD Memorial Award as SNMPI PET Center of Excellence, Distinguished Services Award, Best Mentor Award of USC and ACNM, Best NM Teacher Award of USC Radiology, Professor Ajit Padi Memorial Award from Warmth, and a Fellow of ACNM and SNMI. Selected professional activities. He has also been the past president of ACNM, past president of SNMMI, president SNMMI Therapy Center of Excellence, vice chair of US Nuclear Regulatory Commission Advisory Board, director ABNM, associate editor of JNM, EJNM, MI, CNM, Radiology, Theranostics, principal investigator with NIH US. I welcome Professor Hussain Jadwar to kindly deliver the oration.
Thank you. Wow, thank you very much for that kind introduction. That's the longest introduction I ever had in my life. But thank you very much. It's great. And I want to thank all the organizers, especially Dr. Choudhary for a kind invitation to be here. And I'm honored to be giving the Dr. R.D. Lele oration at the 21st ANMPICON meeting. So I did not know, I must admit, I did not know much about Dr. Lele, but I actually did my research. And as was already presented, it appears that Dr. Lele was a physician and scientist, a true gentleman. So I came up, and of course, as was mentioned, father of nuclear medicine in India. So basically, I can summarize it as really a gentleman and a scholar. And therefore, I'm really to be giving this oration in his memory. Thank you. So the topic of my lecture tonight is radiotheranostics, then, now, and future. So what I'm going to do, this is the outline of my talk, and what I'm going to do is just define theranostics first, and then since I live in Southern California in Los Angeles, and that's the home of the Disneyland, so I thought I'd use that theme. And there are 2 theme parks in Disneyland. One is called Frontierland, and under that I'm going to talk about some of the molecular targets that we have been using or are using in nuclear medicine. And then under the theme park of Tomorrowland, some of the other biological targets that we may be using in the near future. So you all know about the concept of theranostics, and basically it's divided into three parts: that you have to identify a biological target that is relevant to cancer or whatever disease process you're looking at. And this is really under the auspices of understanding cancer biology. So as our colleagues dissect the complex nature of cancer biology, we come up with new targets that may be amenable to both imaging or treatment. Of course, when you have that, these biological targets could be anything. They could be transporters, they could be receptors, they could be enzymes, something that is relevant and is different between a normal cell or a benign tissue and a malignant cell. Then we design a molecular ligand based on what this biological target is. This could be in form of antibodies, it could be in form of peptides, amino acids, or other things that gets designed to target this biological marker. And then, of course, through a linker, we can connect it to a reporting unit. The reporting unit is for imaging, and it can be a single photon or a positron, as is listed in here, or it can be a cytotoxic unit instead of a reporter unit. So then we are using exactly the same molecule for treatment purposes, and you can have beta emitters there, you can have alpha emitters there. So the concept is really aligned with precision oncology if you're talking about cancer as the disease, and it's the concept of seeing what you see. So it's a bidirectional centered concept. So let's talk about under the frontier land, radioiodine. No, this radioiodine is basically the birthplace of radiotheranostics in our field. It's based on sodium iodide symporter, as you can see up here. And I want to acknowledge Dr. Saul Hertz. Unfortunately, he only lived 45 years, but he was the very first person who performed radioiodine in treatment of a patient with thyrotoxicosis. Back in 1941, the endocrinologist that thyroid accumulates iodine, and he asked at a meeting that was given by the MIT president, who's a physicist, asked him, is it possible to make it was radioactive, then he could treat the thyroid? And they said, yeah, maybe we can do that. And they went across the Charles River in Boston, and they had not on 30, on I-30, as you can see here, with a half of they just to Dr. Hertz, and he treated the patient of theranostics. Later on, Dr. Seiglin performed the first radioiodine treatment in thyroid cancer. And when I was president of the Society of Nuclear Medicine and Molecular Imaging between 2015 and 16, one of my initiatives was to establish the SNMMI Therapy Center of Excellence to bring focus to nuclear medicine treatments and theranostics. And soon after that, we established this, received by many luminaries in the field to commemorate the contributions of Dr. Saul Hertz. And in fact, as you can see, the radiotheranostics essentially is 82 years old now, as of today. So, but I just show you this one image, just to show you. This is a patient with rising thyroid globulin, but as you can see, the radioiodine scan is negative. So, not always, it is not always that you can see something using this radiotheranostics platform, and you may need some other diagnostic tool to tell you what is going on with this patient. And you can see this patient actually had a positive FDG adenopathy in the neck. which was invisible or not avid for radioiodine. So sometimes you have to also depend on other tools. So let's quickly move on to SSTR, somatostatin receptors and neuroendocrine tumors. Again, this is an area that is very active. It is approved and used at many centers. These are neoplasms of the cells of endocrine and nervous system origin. They can be benign or malignant. They have a feature of some of them releasing hormones, and that's why patients have symptoms. Unfortunately, 70% of this disease is metastatic at the time of presentation. It is a relatively rare disease, but the incidence is increasing. That may be due to the fact that we are having a better way of diagnosing them. And of the type of tumors that we are involved in this case, like lymphoma and others. And that is what we are using as biological target, not only for imaging, but treatment. Receptors, the SST in immunohistochemistry, there are different types of ligands that have been designed to target this somatostatin receptor, as you can see, is one of what we passed. Have been designed. You can see the DOTA, TOC, NOC, and TATE. Those are the to GAD68 as a positron emitter. There is a copper 64 DOTA gallium 68. Type 2. The gallium 68 DOTA tape, relative in spleen and